Okay, thank you. It's after a long time, Vijay, that I am debating. But the only thing is that I have learned is that I should actually check my emails much more carefully. Before today, Sahu, when you called me up, I didn't realize I was debating against you. So then I have stopped all my OPDs, and all that I have done in the last 5 hours is to look at your photographs on the internet. So my confessions before I begin the debate is about the art of oncology and science of oncology. Most of the people know, Kumar and Kumar, Senthil, me and Sahu are from the same college. And whatever little science and art of oncology I've learned is I owe a lot to them. And what Dr. T.B. Sahu, my esteemed senior, has told me in the first day when I joined oncology was do no harm. I still remember Sahu was telling our patients, hey, you should always be very, very careful with them and avoid a remedy that is worse than the disease. Unfortunately, Dr. Sahu, I think I'll need to give you a lesson in that only today. So I'm going to speak for third generation TKIs today. And my first reactions, I've been reading a book called as Ikigai. That's a Japanese secret for a long and happy life. And it basically says, you put that person at the center and decide about what you love, what you are good at, what you are paid for, and stuff like that. My first reaction when I see a stage 4 lung cancer patient is basically about understanding what a lung cancer patient, actually stage 4 lung cancer patient basically wants. What the patient basically wants is a good drug, which basically has an increased PFS and OS. It crosses the blood-brain barrier. It should be oral, ease of administration, and probably if it is, good quality of life. That is what I would want if my attendant was basically had a stage 4 lung cancer. With this in mind, let's go and look at the two data. I'm going to speak for third generation and Sahu is going to speak for combination. Let's look at the osimertinib data. All of us have seen the data. This was a double-blind study design, not the open label which other trials are. The PFS was the first primary endpoint actually over here. These are the 6 goals that I have written: PFS, ORR, increased OS, good CNS, good quality of life, and please avoid chemotherapy. That is all that is there. So let's look at the primary endpoint. And today I'm going to give you some lesson in statistics also. Let's look at what the PFS, the primary endpoint was PFS, and look at the early separation of curves over here. The moment you start giving them osimertinib versus gefitinib, the people start to be improving. This basically means that osimertinib is a better drug and lower incidence of resistance mutation to osimertinib. Also, please, Dr. Sahu, I know you're going to make a lot of hue and cry about L858R and Asian subgroup. When it was powered for the for the PFS, that was the primary endpoint, there was no difference whatsoever. So there was a longer PFS, absolutely okay. Was there a longer OS? Definitely there was a longer OS. Again, this was statistically significant. Now, Dr. Sahu, please remember this: increased OR, increased overall survival. The numerical value of overall survival will come to later. Now, what about the CNS activity? We all know the CNS activity of osimertinib is fantastic. Now, osimertinib demonstrated a superior systemic PFS benefit, whether you had CNS disease or whether you not had CNS disease. And if it obviously responds to CNS, the incidence of radiotherapy to the brain actually comes down. What about the patterns of relapse, CNS versus extra CNS? The CNS patterns of relapse are actually lesser in the FLORA trial. And I do not want to even show Dr. Sahu about the ADAURA trial because, hardly 1% of people relapse in the CNS. So that's also a very, very, very good thing. Now, what about osimertinib in leptomeningeal metastasis? I'm sure Sahu has a better experience than me. And this was a Bloom study, which basically said, that you had a response of 62%, and the overall response was around 41%. The median duration of response was around 8.3 months. Leptomeningeal mets, ask any oncologist, and I'm sure Dr. Sahu will tell, it is a bad news for the patient. It is almost like a death sentence. Osimertinib, single drug, giving you a DOR of 8.3 months is absolutely fantastic. Sahu will say, this is all happening in the West. Where is osimertinib, our data? So I showed him, let him show him my data. This was the data which was presented in our this thing. It was published at ASCO, and we had given it to 12 patients actually, and our patients, the median leptomeningeal PFS and OS was not reached. The response rates were around 60 to 70%, and this is actually APNA data, I'm sure, which we are all very proud about. So the 4 boxes tick. Now, what about the grade 3 adverse events? You had a 38% grade 3 adverse event. I'm sure Dr. Sahu is going to show you this. Frequency of dose reduction 4%, treatment discontinuation 13%. Fantastic. But look at what were the adverse events. You had diarrhea, you had rash or acne. I mean, come on. Diarrhea, rash or acne, decreased appetite, a grade 3 side effect. I'm sure we have given much more toxic chemotherapies and transplants than this, and oral medicine can easily surpass from there. Quality of life of both the oncologist and the patient is much more better if you give an oral tablet, and obviously the patient is getting much benefit. Now, what about the time to subsequent therapies? Time to first subsequent therapy is 26 months. Time to next subsequent therapy is 31 months, which is also much higher in the osimertinib arm. So this is what my, this is what the osimertinib will be asking at this time. What more do you want from me? And Dr. Sahu, bacche ki jaan loge kya? Which I'm sure you will. And the bacha actually right now is me. But this is my point of view. And this is what oncology you have taught me. Now, let's listen to the other side of the debate, which Dr. Sahu will come. And this is not the other side of the story that is important. Look at the ones, questions everything. We will question everything. We belong to a ex-party. Election season hai. Kuch bhi bol do. Log maan lenge usko. This is what Sahu wants to believe. If you are alone, you obviously want a partner with this. And Sahu basically wants a combo offer. Maybe Dr. Sahu is by and large having a middle life crisis where he wants a good partner actually over there. So this is what Dr. Sahu wants. We'll question everything over here. This is what Dr. Sahu will show. Three trials, fantastic trials. One was the Japanese study, 53 months survival, one is the data which is very close to my heart. Honestly, didn't want to criticize this data for love and affection towards Kumar and Ranoa, but I'll have to do it. And this was the Chinese study which Dr. Sahu will show, which showed some advantages. So this is what Dr. Sahu wants us to see. The combination arm is exactly going to be, like a honeymoon lasting forever. And this is what Dr. Sahu also, look at Dr. Sahu alone and look at Dr. Sahu all shaved up in company of a good combination partner. But unfortunately, Dr. Sahu, that's not how it works. You are telling us all the stories about what happens pre-Valentine's Day. I will show you stories in the Valentine's week about what happens post-Valentine's Day. Let's welcome to reality. Let's analyze the data. I will show you the first data, 52 month survival, the NEJ009 study. Gefitinib alone versus gefitinib plus chemotherapy for non-small cell lung cancer. Please remember, now look at this, Dr. Sahu. What are the primary endpoints? PFS1, PFS2, and OS. These are the primary endpoint. If your statistical hierarchical design did not say PFS1, PFS2 was superior, your OS could not actually be reached over there. And following gefitinib, patients all got pemetrexed cisplatin. So either you got gefitinib pemetrexed cisplatin or you got gefitinib followed by pemetrexed cisplatin. What happened? This is what Sahu will show you, 20.39 versus 11.17. What Dr. Sahu will not show you here is that if you give gefitinib followed by pemetrexed cisplatin, by and large the same amount of benefit you can get. This is the ASCO 2021 presentation, Dr. Sahu. Look at the toxicity profile, I mean, just imagine how many patients. I showed you 38% people with osimertinib may get some toxicity profile. Look at the toxicity profile. 66% of patients are actually getting toxicity profile. And what are the toxicities? Leukopenia, neutropenia, anemia, thrombocytopenia, liver dysfunction. These are not your simple toxicities such as liver dysfunction, etc. So this definitely is toxic. What about the global quality of life? While you are taking chemotherapy, Dr. Sahu, look at this. Your quality of life actually decreases initially in the chemo upfront arm. Now, this is my punchline, Dr. Sahu, which I read today after you told me that you are debating against me. This was the ASCO 2021 presentation, which says updated analysis of NEJ009. And I'll read it for you. Busy slide. Please read it properly. And maybe you will not debate after that. 345 patients were assigned this. At the latest data cutoff, there was no significant difference in overall survival. No significant difference. And you will show me the subset analysis HR data 0.82 and the confidence interval is 1.06. So this trial was a negative trial as far as the OS and the PFS2 was concerned. Again, you will show me the following subset analysis 0.5, 0.77, 0.82. Please see these also, Dr. Sahu. I am sure that is what you would be wondering about. Ye kya hua? Kaise hua? Kab hua? So I will tell you some more things, Dr. Sahu, which will happen. You would be very fond of showing me some subset analysis data about Asian subgroup and non-Asian subgroups and stuff like that. Now, this is the subgroup analysis of your best data, that is from Japanese. Females, this does not benefit. Your chemo combination, this does not benefit. HR of 1. Non-smokers, it actually doesn't benefit. Also look at the EGFR 19, 18. All the confidence intervals are crossing the unity. So please be wary about this subset analysis of an underpowered analysis. Actually, subset analysis of OS can be seen over here because it's a primary endpoint. So please remember this, Dr. Sahu. Do not show me unplanned subset analysis of the FLORA data. Now let me come. Oh, what did the authors say actually? The authors actually said in their own paper that patients with poor PS with symptomatic CNS mets should actually get osimertinib because they may not get treatment over there. And they also said the OS benefit requires further validation. So your overall survival, Dr. Sahu, is not increased in the NEG 009 trial. And this is straight from the horse's mouth. Now, this is what was the TMS data. And again, before I begin criticizing this data, huge round of congrats and appreciation for Kumar and Vinita, because they did something that I'm very dying to do something. But for the purpose of debate and for the purpose of science, I have to do this. So look at this. 712 patients were assessed. Only 350 patients were randomized. Koi baat nahi. It is India. Sab chalta hai. Now look at this. If you look over here, only 80% patients completed 4 cycles of pembrolizumab carboplatin. 14% patient received 3 cycles, 5% patient received 2 cycles, and 7% received only 1 cycle. 13% patient required dose reduction because of toxicity. 39% patient had dose delays. I mean, what exactly are we trying to do by giving them chemotherapy and this? Now, comparing all toxicities, 38% osimertinib, 75% Japanese study. Here we have 75% patients who had a grade 3 toxicity. And again, if you see the clinically significant toxicities over here were seen in 50% of patients actually. I mean, I'm sure Dr. Sahu, you will be saying it is hard. Now look at the CNS data. I showed you 15 months of PFS data. Look at how many people have got whole brain radiotherapy in this. 13% people in the Jeff plus C arm actually have got the radiotherapy also in this, which is not a very nice thing. And I'm sure this is what Dr. Sahu would actually be doing right now. So this was the letter to the editor by one of the people who criticized. They said the data was assessed not by an independent observer. It was actually assessed by the thoracic radiologist only, which is also not a very nice thing, because all this data should have been assessed by a blinded independent central radiological review. This is not what I say. This is what Tony Mock says. Now look at the positive HR. The control arm actually underperformed. Your median OS was only 17 months. The median PFS was only 8 months. I did a bit of calculations. If your median PFS in the Indian study was 11.9 months, your HR value, Dr. Sahu, would have been only 0.8. The quality of live data was not there. There was more toxicities. Very few people got osimertinib. You didn't ask the patient what they want, and the cost effectiveness was lacking at that particular time. Now, what about the addition of anti-angiogenics? I don't want to spend much time. Look at this curve, Dr. Sahu. Again, OS is not benefit. When you talk of FLORA, when you talk of when you talk of other drugs, you want OS. Here, you don't. Are you happy with only a PFS advantage? Again, look at the toxicities of NEJ 0026 study. There was no OS benefit. 91% patient had a grade 3 or grade 4 event. Whom are we trying to impress by giving drugs like this? What about the Relay study? The PFS is more. I know you will tell me about the L858R and the Del 19 story and everything, but no OS benefit as yet. The CNS mets were included over here, which are 20% of your patients. Safety profile is of concern again. And Dr. Sahu, I'm sure you're going to tell me about the cost. Have you ever calculated the cost of erlotinib plus ramucirumab? Unless or until Lilly gives it for free and patients have to come twice a week over here, it's not really worth coming over. Again, Dr. Sahu, I'd like to remember you, your cure cannot be worse than the disease, and this is one you should do no harm. Let's do a cross-trial comparison. PFS increased in everyone. OS increased only basically in the FLORA. The TMA is the KN regimen. It has not been reported as yet. Brain penetration, yes for osimertinib. Toxicity profile, better. QOL data, better. What more do you want? So, what will Dr. Sahu debate today? He will tell me about the subset analysis. He will show me the he will show me the EGFR and the Asian study. But again, that wasn't secondary analysis. That was not a primary analysis. And again, as a secondary endpoint, the study was not powered for the same. Subset analysis will be of a secondary endpoint, Dr. Sahu. I am sure, tum karo to alag or hum kare to galat. That is not very nice over there. This is a Chinese flora study. Again, thank you, Dr. Sahu, for telling me about the Chinese, the Asian subgroup. Again, this study basically showed that the median PFS in the Chinese patients and the non-Chinese patients were by and large the same as the global flora group. So I don't think Asians behave typically different from a non-Asian patients. Dr. Sahu will also tell me what after osimertinib, the disease is bad, this is everything. So Sahu, if you have any patient or anybody is any patient, we have 4 trials going on right now for patients with post osimertinib. We can give them capmatinib, we can give them savolitinib, we can actually give them combination of amivantamab, lazertinib and chemo versus chemo alone. And these trials are currently recruiting not only at RGCI, at other centers also. He will now then tell you, rare mutations. The Vinita studies also took people with rare mutations, but again, so has osimertinib been tried in rare mutations. And again, if you read over here, there is a favorable activity with manageable toxicity profile with that. And I'm sure this is what Dr. Sahu will say, or Vijay will say, ki bas kar pagle rolayega kya. But I thought one more point, last point, cost. This is something which I have just taken from my medical oncology group, and this is what Dr. Parekh says, How many times do we hear comments in the oncology meeting that my patient cannot afford this drug, that drug, but that's not how the science really works. This is what exactly the editors had to say after the Vinita paper, that patient without access to OC, maybe this can be tried. But patients who have got to access to osimertinib, the data are provocative, but they have not yet demonstrated superiority. Now let's look at the Japanese guidelines. Japanese had a highest number of 52 months, and look at them. 93% of them will recommend osimertinib. Only 18% will recommend geftinib plus chemotherapy. 4% will only give them geftinib plus anti-angiogenic agents. What is the first line treatment for ECOG PS2? Japanese study. 86% of patients will say some amount of oral TKIs we will give. What about the guidelines? We will quote NCCN guidelines. I looked hard, and I looked at osimertinib. I could not actually find chemotherapy plus osimertinib in this. What about the Pan-Asian guidelines? This also says osimertinib is the best, and this is the best. This is the best. Guys, small print, sorry. This is the Indian guidelines, and which again says osimertinib is the preferred option. And I looked at the names over here, Kumar Prabhash, Amish Vora, Sevanti. Then there's a name called Tarini Prasad Sahu, which actually just comes before me. Tarini Prasad Sahu in practice agrees that you should give osimertinib, but in debate he wants to give chemotherapy. That's not really a very nice thing, Dr. Sahu. Now, while Dr. Sahu was celebrating Valentine's Day with his combination partner, I was actually reading February 14th, the ESMO latest guidelines, and again this said only this much, only osimertinib should actually be given. There were 31 voters. 30 people said yes, you should. Only 1% abstained, and I'm sure that was Dr. Sahu who conveyed. What about the real life study? This is what the real life study, which shows there are 2 studies which again show 20.5 months of survival over there. So let's go back to our clinic. You have a patient which comes to Dr. Sahu, who says, okay, the patient comes to him and says, I know you have stage 4, but the good news it is EGFR mutant. Patient says, doctor, I'm so lucky to have you as my doctor. Doctor, give me the best treatment. I don't want to suffer. Oh, Dr. Sahu says, I will give you treatment of combination of TKI and chemotherapy. Patient says, chemotherapy? Doctor, but I have got a lot of your videos over there which says, you talk about personalized therapy. Is there any other option available? Dr. Sahu says, yeah, but the patient says, is the combination therapy that you're proposing less toxic? Sahu says, no. Patient says, is it with better survival numerically? Sahu says, no. Patient says, I hope I'll be able to tolerate it well. Sahu says, no. Patient will ask, I'm sure it has got a much better CNS penetrability. Sahu says, well, not exactly. So then they say, okay, fine, let me take this initially. Maybe I'll be able to take osimertinib later. Sahu says, not sure of that also. The patient says, then finally, Dr. Saab, is there any other way out of any way out of this? Sahu says, okay, fine, just let's not discuss anything more about it. Also, again, take a hypothetical scenario. If you have 100 EGFR mutant patients, 20 will have brain mets at presentation, osimertinib better. 15 will have poor PS, osimertinib better. 30% will never get osimertinib in the second line. Osimertinib again is better than this. 20% will be elderly. Osimertinib will be better. So what exactly do you want to give chemotherapy plus TKIs into? So this is what osimertinib is, non-small cell lung cancer is. Whether you look at ADAURA, whether you look at FLAURA, the results are great. If chemotherapy plus TKI was so good, then why not try it in first stage 1, 2, and 3? So this is what the perception on reality of TKI based combination. This is what Dr. Sahu actually wants to show, EGFR TKI combination. But actually, when you come to clinic, this is how they fall on their straight on their face. This is what Dr. Sahu exactly showed you on the left about the girl and the combo therapy. The actuality of this is actually this. So with this, I rest my argument that maybe single agent combination therapy is the way to go. If you want to try with combination, this is the only combination that works, and that's it. And now looking to learn from Dr. Sahu. Thank you. Get back to you.